Good morning to everyone in the United States. Good evening to everyone in China. My name is Christian Shilcott with Baird Medical in the United States, Betters in China. I'd like to thank you for joining this morning's call, and this evening again, if you're in the China. We will be beginning the meeting momentarily. Again, thank you for joining. As Professor Han was setting up.
Hello, can you hear me?
Good evening. Yes, we can hear you very well. Thank you.
Thank you. Thank you. Oh, it's sorry to the Professor Joe can't come here for some technical reason. Now, let me introduce something about this meeting. First, good day, experts and colleagues. Thank you for coming to our academic exchange meeting on thyroid ablation using microwave. Thank you for coming to our meeting. With this time, we mostly introduce our experience about using the microwave treating superficial tumors, especially for the thyroid. During this year, with the continued improvement of the healthy awareness, the country's increased attention to the development of medical health and the development of the new technology. Many favorable factors have emerged for the development of microwave ablation of the thyroid gland and the therapeutic technique. Microwave ablation is a new surgical treatment model that uses image-guided technique to convert a classic invasive model into a minimal invasive model, creating a new diagnosis and treatment development model for both patients and the medical sector. We expect that microwave ablation will play an increasing essential role in tumor treatment in the future. We also hope that all the professors would contribute and discuss their ideas and station for the advantage of the thyroid microwave ablation technology. And thank you, everyone, and have a good day. Now, maybe this is what I said for the Professor Joe. Now, maybe we can start our meeting. First, I introduce myself. My name is Han Feng, come from the South China. We belong to the university, the Sun Yat-sen University. Our hospital is the Sun Yat-sen University Hospital of Cancer Center. Now let me share my slides. Okay.
And thank you for joining us very much, Professor. We really appreciate your attendance.
Thank you. Okay.
Hi, Dr. Yang. This is Dr. Yang says already attending the meeting.
Okay.
Yep, we can see them very clearly, Doctor. Thank you.
Thank you. Thank you, everyone. It's my pleasure to be here to introduce my work about the microwave ablation. Actually, we not only treat the thyroid, so this time I will introduce some of my work about the superficial ablation. As we all know, the interventional radiology was guided by several kind of techniques, such as DSA, CT, MRI, or some other ways. But it's very complicated and very huge sometimes. Ultrasound has some advantages this time. This picture show one time I go to a very small hospital, teach them how to use the ultrasound to get the biopsy. You can see we just in a very small space with very poor condition. So the ultrasound has some advantages. As we all know, it's real time. We can see the needle all the time during the biopsy or the ablation. So it's very good. And there's no radioactivity. It's safe for people, all the people, including the patient and the doctors. And it's very convenient in the effect monitoring. Especially we have some new techniques such as the contrast ultrasound. For the superficial area, the ultrasound has much more advantage than than other place because the superficial ultrasound has a very high resolution. We can see very small structures, even less than 1 millimeter, and has high freedoms. We usually do the biopsy or the ablation with free hand. Don't need to the structure to get our needle. Finally, we also have less interference such as the bone or the gas. It's very clear to find the lesion or find the needle. There are two samples for to introduce the superficial ultrasound. We can see this is a patient after the operation of the thyroid. It's a PTC. We find a lymph node in the side neck about level 3. Inside the lymph node, there are very small bright place. It's very small. It's only about 1 millimeter. So we decided to have a biopsy. We can see this is our needle. We can get the needle to punch the small needle very correctly. And finally, confirmed it's a metastasis. The second case is about a heart. We can see this is the heart. It's jumping. In the surface, we can there's something in the surface of the heart, and we get the needle put to the mass and had the sample. Finally, confirmed it's a mesothelioma. So he can get a next treatment with in our hospital. Can see. This is the needle. Oh, here. Okay. When we talk to the ablation of the thyroid, or the maybe two kind of technique maybe talking about. First is a fixed needle ablation. That means we put the needle inside the mass and heat. With the time consuming, the area become bigger and bigger and cover all the region. The next one is the most common one, is the moving shot. What's the moving shot? Is we just separate the region into several slats. In each slat, we just moving the needle from one side to another side, and finally cover the whole slice. Then we cover each slice, make sure all the region was covered. And another technique I want to introduce is hydrodissection. That means we separate the
Dr. Han, I don't know if you can hear me. We seem to have lost you for a moment. It looks like the video feed may have come to a stop. There we are. Now we have your video again running through hydrodissection. Let's see.
It's
Yes. Hey, Dr. Han, I don't know if you can hear me on your side. We can see the cursor moving, so there is connection of the video. Unfortunately, we have lost the sound. We do have the slide titled Ablation Strategy that is fixed. Now we hear you. I can hear you now.
I just wanted to introduce this
Yes,
page.
perfect.
Yes, okay. Can we
Yeah,
go on?
Yeah, we hear
Yes.
you very clear. Thank you very much.
Okay. Now I'll introduce what we usually do when we face different kind of nodules. First, when we face in the solid nodule, when it's big, we usually take the moving shot technique, just one by one, make sure it is covered. When we facing the small ones, which most is PTMC, we use a fixed needle ablation. Just put the needle inside the nodule and heat and make with the time consuming. We make sure all of the nodule are treated. When we facing the septic or almost the transeptic nodules, when it's very big one, when we do the FNA, we usually do the atherosclerosis in the same time. But then if it's not too big, we just drain out the liquids when we do the ablation.
Understood.
Okay.
Do you
okay.
I'm just going to ask you a question. When you do the FNA, do you do the alcohol post FNA procedure?
Yeah, in the same time.
Okay, perfect. Thank you.
Okay. Now I will introduce what we did from the thyroid about the thyroid, the parathyroid gland, or lymph node, or breast. First, let me introduce some our case for the benign thyroid nodules.
Great.
Okay, maybe I should slowly. First, let me introduce a static one. This is not too big, so we didn't do the chlorosis. We just drain out the liquid before we do the ablation. We can see. We just put when we finish the local anesthesia, we use the same needle.
What size needle do you typically use here, Doctor? What gauge? We can see your sound's out a little bit, so I will help. You can see your ablation on the bottom side of the nodule. Working from the bottom and the distal portion of the nodule, working upwards in the moving shot technique. So 91% reduction from 1 month from the initial ablation. So from 40 by 28 millimeters, 1 month later, the measurements at 16 by 13 millimeters. So significant reduction in just 30 days. Very impressive. And now we can see we've moved to a solid nodule. So after the procedure, you're injecting contrast through the vessels to ensure that there is no bleeding post-procedurally. And Dr. Hahn, if you can hear me, the sound is a little challenged, so I'm trying to help you. If I say anything that is inaccurate, please correct me in the chat or somebody else. But understanding that contrast was done with imaging before, ablation was done, and then contrast imaging after to ensure that there was no post-procedural bleeding that was not there prior. The vessels are all intact. So in this case, nearly 60%, so over half of the nodule size is reduced at the 6-month point from 42 by 28 millimeters to 27 by 18 millimeters. Impressive results. Very nice. So not only clinically significant, cosmetically significant, and if you notice, you can barely see, if at all, where the initial or the ablation point was made to treat. So eliminating the scar that would have occurred had this patient needed to undergo surgery, just several years ago, as the major, and still in the United States, still a major treatment regimen, as we are slowly adopting minimally invasive ablation therapies here in the US. So this is a great example of the benefits to the patient, and that these physicians are pioneering these techniques and procedures, not only for clinically improvement, but cosmetic and patient care. And for those of you that are listening, there is some work going on behind the scenes to get the audio working. It wouldn't be a Zoom meeting in these days if there weren't some audio challenges. So we appreciate everybody's patience and appreciate Dr. Han as he's working through. So now we have a new case study. If I'm understanding it correctly, we have 13, is either a male of age 13 or 13 nodules of 4 millimeters. Brought in, done for local ultrasound, then ultrasound, and then a physical test, then another ultrasound, and then preparation of ablation to drain out 500 milliliters of fluid, followed with alcohol sclerotherapy twice prior to ablation, done in July of 2021. And then a month later, the patient was prepared and ready for an ablation procedure. The bottom left slide, you can see the ablation procedure. We may have lost Dr. Han. I'm going to ask one of my colleagues, Eric. Is Dr. Han logging off and logging back in to correct?
He's trying to reconnect.
Okay, great. So we'll give him a moment to connect, and hopefully that will correct the audio issues. Well, while we wait, if you don't mind, got you when you had your camera off, but I'd like to welcome Dr. Raymond Hume from New York City. Dr. Yoon trained years ago at NYU, so very, very well trained and accredited university. And Dr. Yoon will be speaking here shortly. Has started his own practice long before many of the others in the United States began their freestanding centers. For those of you in China, I know these procedures are more done in academic centers. In the United States, you have a blend of universities and academic centers tend to pave some of the initial procedures, but then there are also freestanding centers where physicians, entrepreneurial physicians such as Dr. Yoon, will open their own clinic. And there's a lot of reasons why this is beneficial to the patient. They are able to, park a lot closer and not go through all of the hassles that are required at a hospital. And they are in and out much more quickly. It's a much more personal level of care. And that's a model we see in a lot of procedures here in the US, and starting to become more prevalent for the treatment of thyroid nodules. So we will be hearing from Dr. Yoon, and he is on a tight time schedule this morning, so we appreciate him joining. Now we will return to Dr. Han. Dr. Han, how are you? Can you hear me okay? And we can see if we
Yeah. I can hear you.
Well, yep,
Yeah, I'm back.
loud and clear.
Oh, okay. I try to change to myself, and maybe it's better. Okay. I continue introduce my PPT now. Thank you, Christine.
My pleasure.
It's a 13 years old children. He has a mass in his thyroid, and several masses. It's not only one. It's about five nodules in his thyroid. He ready to have ablation in the summer vacation. When he waiting for the ablation, he had a PE test in 2020, but the neck become very huge. You can see there, as we all know, there may be some bleeding inside the nodule, but he's very tough. He's still waited to the summer vacation and come to us. Because it's too huge, so we decided drain out the liquid, the blood first, then do the sclerosis 2 times before the ablation. Yeah, we use about 2 weeks time to drain out the liquid. You can see we put three tubes inside the neck, drain out about 5 milliliters. Then
when
we
you
had
do the sclerosis, does that help with hemostasis in the areas of bleeding? Is that the intent of the sclerotherapy prior to ablation?
I think it's very useful. We do the atherosclerosis before the ablation. It can reduce the bleeding when you do the ablation. Usually with the cystic nodules, when you drain out the liquid inside the nodule, it will appear again very soon, maybe 3 or 2 minutes, you will find it refilled. So it's hard to treat them.
Understood.
Become hard. So if we do the atherosclerosis, it will be better. Reduce the bleeding chance, I think.
Great, thank you. That's what
Yeah.
I wanted to make sure.
And also actually all the nodules has some solid parts. So we not only treat the border, also treat the solid part, make sure there's no bleeding later. Okay, this is the ablation, and this is what we saw. It's just before the ablation. Okay, this is just finished the ablation. 3 months later, we can see the neck becomes normal.
I mean, that's an amazing improvement.
Yeah, the boy become handsome again.
Absolutely.
This is what based on our experience. We separate the nodule to according to the cystic proportion to 1 to 20%, 20 to 80%, 80 to 100%. This is the time, and this is the follow up. The VRR, the volume reduction rate. We can see the cystic one is much better than the solid one, but finally it's very well about 1 or 2 years later, and it's very similar to other studies we can find. Okay, next, I will introduce some experience about the PTMC. This is a 38 years old female. We find a very smaller, about 7 millimeter by 5 millimeter. This one in the left lobe bone. And we had the biopsy confirmed it's a PTC. We also had enhanced CT, make sure there's no lymph node metastasis. So let's see the nodule, the lesion. It's very small, 7 by 5 millimeter, and it is far from the capsule. And it is also confirmed as a PTMC, no lymph node metastasis were found, and the patient has a strong desire for the ablation. So before the ablation, we also did the CUS, make sure the lesion is active. This time we treat it with a fixed needle ablation. We can see we put the needle just in the center of the nodule. We can now start the ablation. You can see the area become bigger and bigger. It's very soon. About 1 or 2, about 1 minute, I think it's enough. After the ablation, we can also do another time of the CUS. You can see the lesion is very small here, but the area we ablation is big enough to cover the lesion. This is the other side. Okay. After 1 month, we also did a CUS to make sure there's no left. Okay. 6 months later, we can see there's only one become very small, almost can't be seen this time. To our experience, we find about more than 1/4 of the patient with PTMC after the ablation maybe it could disappeared. Okay.
So 1/4
Next,
of patients almost
yeah,
completely disappears.
yeah, almost disappeared. Okay. Can you see my PowerPoint?
We can.
Yes. Okay. Okay. Now let me introduce some about the metastatic lymph nodes of the PTC. This is a female, 66 years old. Unfortunately, he had several times. He had 3 times of the operation, but every time he had lymph node there. Over there on the right side, just behind the artery, it's attached to the artery very closely. Can't be separate. The third time, the last time he had the operation, that's a very huge bleeding. So when he come to our hospital 2020, he found it's very hard to have another operation. So he went to us. We had we think maybe the microwave ablation will help her. So at Europe, we treated her with the CUS, make sure, oh, this is the target. It's very, very bright. You can see there are many blood inside the tumor. And we had the ablation. After ablation, we have another time of the contrast enhanced ultrasound, make sure all the tumor was treated. Okay, now we follow up.
If I may ask that, and for some of the earlier, younger people on the call that are earlier in the learning stage, how did you begin as you learned these minimally invasive procedures to utilize Doppler before and after early on, or was that something you evolved into? And I asked that question because when I see procedures in the US, very rarely is Doppler done to look for bleeding pre and post procedurally, but in China, of course, it's much more common.
Yes, CUS in China is very common, especially for ultrasound doctors. I think it's very simple for us. Just inject a very small dosage of the liquid. This maybe only 1 millimeter is not millimeter. 1 cc is okay. So and all the procedure of the CUS consume only need 1 or 2 minutes, so it's very soon and very easy to do. So it can improve improve the effect very much. So I think it's very really very it's a very good selection for the patient.
Of it, very little effort to prove something that could be,
Yeah.
problematic. So we're worth the time and worth the effort. I agree.
Yeah, it's worth to do. Okay, now let's follow up. It's 1 year's time to follow up. Up to now, it's almost 3 years. We can see the tumor become smaller and smaller. 1 year later, it is only 5 by 3 millimeter. Now, about 3 months ago, he come to us again. It's similar. It's no more other tumors were found. I think it's very good. Okay. Next, we'll introduce the ablation of the parathyroid gland. As we know, there are 2 kind of situations. First is you like these people is 50 years old, 50 years old male had a left mass about 42 by 29 millimeter, and he had a hollowness. After biopsy, we confirmed it's parathyroid nephron, and the PTH is very high, it's more than 140. So we treated it microwave ablation like this. After ablation, make sure there's no place left. So 2 months later, he come to us for the follow up. We find it's smaller. The VRR is about 57, and the voice is normal now. He can speak very well. He's a text driver, so the voice is important for him. And the PTH come to normal. It's about 37. Another kind of situation for the parathyroid glands is the renal failure patients. They have the renal dialysis, so the PTH may be hyperplastic. In these patients, we must find all of the at least 4 parathyroid glands. This patient, we can see he had a PTH about 2,000. 2,000 not the real situation, because the limitation is 2,000. We can see we find all of the 4 glands. This 1, 2, 3, 4. This is the right top, right lower, left top, left lower. Okay. Left upper one, we can see in another side, it is very long. So we treated the 4 glands by 3 different ways. The lower right one, we has a very common route. Just put the needle behind the artery like this. You can see this is the local anesthesia. We just inject the anesthesia from the back of the artery, separate the gland with the surrounding tissue, and put the needle. Okay, now this is the ablation. We just punch the needle into the glands and can push up, then push up and push it away from the nerve. Okay.
Yeah.
Okay. From the upright one, here is the upright. This is the artery. This is the trachea. We just from the inside. You can see the gland is very tough. It's hard to punch into it. We can push it. Also can push it away from the nerve. So can put it here. We can do the ablation very safe here. Okay. The left lower one, this one is a trachea. This is a gland. We can also push. Just this time because it's much superficial than the right one, so we puncture the needle in front of the artery. This is the artery, please. We in front of the artery and push into the glands and pour it to the surface, to the superficial place. Make sure it's away from the nerve. Okay. The upper left one is the most difficult one. We can see we inject some water here to have a hybrid dissection, and from the bottom to the top, along the longitude of the nodule, and punch into the glands to have the ablation. Okay. Now we follow up the PTH. We can see from the the operation day to the fourth day, it dropped very, very much. Okay. Now I want to show you some case about the breast nodule ablation. It's not common in our hospital, but we do some patients. Especially for some very young patients, they will care about their feelings, their appearance. So they don't want to have a scar in their breast. So we do the ablation. It's a 27 years old female. It's a red, only a one mass in his right breast. It's about 27 by 14 by 25 millimeter. And before the operation, we had a biopsy confirmed it's a fibroadenoma. Okay. This is 1 month. We do the ablation from the bottom to the top, from the far place to the near place, and confirmed by the CUS. 1 month later, it's 30% shrink. 1 year later, it's about 60%. I think it's not a very good one because only 6%, but this one is much better. This is a 55 years old female. He has several masses. Actually, we did seven nodules. This is the two biggest one. This is the biggest one in the right breast. It's about 25 by 25 by 12 millimeter. The left one is almost 50 millimeter. It's a really big one. So after the ablation, it shrinks very much. 1 year later, we can see it's about 90% volume reduction. It's very, very impressive. Okay, we also do some ablation for other place. This is a patient, but very unlucky. First, he has one side of the thyroid dissection, but after operation, he found there's too many lymph node metastases and need iodine treatment next. But he has one side, left side of the thyroid left. So she needs to remove this side of the thyroid. But another unfortunate thing is he injured the nerve during the operation. So the doctor don't want to have another operation. So we come to us. We think it's simple. Just make sure the other side of the thyroid is no function. So we did ablation for him. And 1 month. This is 1 month later. We did another time with CUS. Make sure there's no active place. And in the ECT, we can see the left thyroid has no function at all. This is the ECT report. There's no function at all. This is a parotid cleft cyst. He had atherosclerosis 2 years before, but soon after the the procedure is recurrent. So come to us, we did ablation and find when we the follow up, the mass is disappeared. So he feel very good. Finally, I will share a case. This case not is very special, I think. He is male, 41 years old. In 2019, he found a mass in his neck and had a operation. Confirmed it's a solitary fibrotic tumor. It's a benign one, but it's really hard to remove because first the tumor is big, and its invasion. The invasion of the tumor is very much. We can see from the neck, from the many surrounding structures. It was intact. It's hard to remove, and it's recurrent very soon. So up 2 years later, he come to our hospital. First, in the interventional department, they had a test for the patient, but one 1 month later, they found that there's no use at all. The tumor is same as before. So so he had the high-full treatment, high intensity focus ultrasound treatment. But 6 months later, had another MR, found that there's no use too. So we come to us first. We treat it because the tumor is very big, so we treated it with the needle of the liver for the liver. So and with a high power, with 50 watts, we treated it. The ablation. Hello.
I was going to say yes, Dr. Han. I apologize for the interruption, and this is very good. But if you don't mind, we're going to come back to this, and that's very interesting with the HIFU, and we can explain to that only because we have one physician that needs to depart the call here in about 10 minutes, which is Dr. Yoon. So if you don't mind, we're going to shift to Dr. Yoon for just a couple of minutes until he can go, and we will come right back to your presentation. And I apologize for this interruption, but the delayed start has kind of put us up against the time crunch there.
I think it's okay. It's good.
So I'll ask us to transition to Dr. Yoon's slides. And for those of you that were on earlier in the call, Dr. Yoon practices out of New York, trained at NYU, and was one of the first in the United States to open his freestanding private center and do these cases in an office-based setting instead of a hospital-based setting. And for a lot of reasons, it's a much more patient-friendly environment. So are we moving to the slides for Dr. Yoon? Eric, can you let me know the status of Dr. Yoon's slides?
Okay, I will go on.
Yeah, I think Dr. Han, yeah, please go ahead until we get this other deck up. Yours may disappear for a second, but we may as well proceed.
Hey, Christian, can you put me as the host?
You can grab it.
Yeah.
Yeah, Eric, anybody should be able to grab it, but let me actively do it.
Yeah, let me be the host.
Yeah, it's going to have to be done from the transition person because they are the host.
Oh. Okay.
Hey, Eric.
Yes, you can go on. You can continue.
Hello.
I'll let you know. Okay.
Okay.
Yeah, Dr. Yang is here.
Good morning. Dr. Han, it was a very good presentation so far. Unfortunately, I have to go to a surgery in a few minutes. Thank you so much. It's a good opportunity to share with people online and doctors and people who are involved with the Bayer products. And so far, I've been doing these procedures initially with RFA for about 3 years now, almost 2.5, 3 years in my 3 clinics in Manhattan, Queens, and Brooklyn in New York, Greater Metropolitan. I've very good experience with your products and so far, and I think really trying to learn some technical details from Dr. Han, and I paid a visit to him a few months ago in Guangzhou. It was an eye-opening experience. My quick question with Dr. Han is quickly about one of the cases of the parathyroid. Now, you said that the patient initially had hoarseness, and then after your ablation, the hoarseness went away. Do you know why?
I think let me go back to the slides.
Can I hear you well?
Yes, I think it's, you can see here some cystic place. I think it's bleeding inside the nodule. So it's big enough to push the nerve RLN. So make sure recurrent nerve. So make the horizons. When with the volume is reduction, the push reduced. So the voice back normal again. I think so.
Yeah, just a quick observation in the US private practice or even the ablation sceneries. I think unless you're in very big hospital centers, ablation for papillary cancer, even very small, not done routinely. I have several patients over the course of the last few weeks with less than 1 centimeter thyroid asking for thyroid ablation. Even though technically seeing these patients are relatively benign and superficial, I think the sceneries right now and the medical legal climate, especially in New York, maybe other states, is not quite mature. But I really like the fact that this is so easy and a lot of these recurrences relatively superficial. And you've done a great job in ablating some of the delayed metastases from your papillary cancer. One other quick question is, when you do make cystic tumors with the solid, and I have actually gone to several observed centers, and some of the people are not aspirating the fluid out. And one of the reasons is they worried about aspirating fluid, you will collapse the ablation, and you can after immediately if you ablate the solid part, you can encourage bleeding. So what they have done, and actually I've done myself too, is not to collapse the cyst, but just go ahead and ablate the solid part, because if you ablate the solid part and leave the cystic fluid behind, what the cystic fluids do is like a balloon, is keeping the bleeding from expanding. It's almost like a tamponade effect. Have you seen this done?
Okay, thank you, Dr. Yang. It's pleasure to meet you again.
Yes, it's good. It's been several months. Good. Very nice meeting you, Dr. Han.
I just want to make sure you mean when we treat a cystic one, when we drain out the liquid, it's bleeding again. You mean how to treat
No,
it?
it's not. I mean, I have done both, and I have not really seen, because my number is probably not as high as yours. But I think that if you don't drain it and just go ahead and ablate the solid part and leave it alone, have you seen a difference in terms of the outcome?
Actually, I not. I try to drain out every nodule, because I think first, if you drain out, the nodule becomes small. It will make the work easy. First,
I see.
Yes.
Dr. Yoon, your philosophy or your theory was that leaving the fluid in creates the pressure, to your point, like a tamponade to
yeah, exactly. Keep the bleeding from the solid part from bleeding, and some of the papers I've read talked about that.
Yeah. I know. I also read the paper. I want to see in other situation, when we drain out the liquid, it's bleeding very soon, and the side maybe very similar to before you drain out the liquid. in this situation, maybe very similar to what you said, what you're talking about, just like left the liquid inside the nodule. We treated just like what you said, treated the solid part, treated the border, and we found it's the volume reduction is not different. The different not too much.
Okay, all right. So it's good to hear from you,
Yeah.
from your experience,
So
and it's actually
yeah.
It's actually I don't have enough experience, but it's very nice to hear from there. But unfortunately, I do have to run. Thank you so much. You would please continue on with your excellent presentation. I will try to join you in other forms of
Okay.
discussion in the near future.
Dr. Young,
Thank you.
Yes,
Thank you, everybody. Have a good day.
Yeah, have a great surgery.
Yeah. Okay, now.
So now we will
Continue
return to your slides, Dr. Han. So
yeah, thank you.
Eric,
Oh,
or
it's almost done. Okay.
they're very, very interesting. We have either Eric or the colleague in China that is running the transition is currently moving back to your presentation. So we will be there momentarily. And I'll just point out, because we haven't talked about it that much in the United States, but HIFU has been around for a while, and you can elaborate on it. It's high intensity focused ultrasound, and it's essentially the combination of ultrasound and a very powerful coming together for a powerful ablative therapy, and been used in prostate and a lot of other areas. For this type of treatment. And do you see HIFU very often in China? Is it a procedure?
Yes. We the interventional department have HIFU, so they treat HIFU most for the pancreatic cancer, not for the superficial one. This time, also their first time to treat the superficial tumor.
Understood. And the benefits are it's able to penetrate, percutaneously without causing, an incision or a cut. Correct? You're basically able to target something within the body without making a cut or an incision or a needle stick. Correct?
Yeah.
Okay.
I will go on my presentation. Okay.
Yes, absolutely.
Yeah. Now, after we have 5 times of the ablation, finally, every time the tumor becomes smaller and smaller in this size, not the longitude, just the short size, short diameter. It becomes smaller and smaller. The patient, the neck seems normal, and he can move his head. When he come to the first time he come to our hospital, you can see is a huge tumor, and his head was pushed aside and can't move, so he feel very painful. After 2 times he can move his head and feel comfortable. After about 4 times, he can his life come to I think he told me he have a normal life, and he also know it's hard to kill the tumor, and he decided to live with the tumor peacefully. So he told us, maybe I have ablation every half year. So every half year to come to us and have a check to make sure the tumor isn't big enough, or it should be treated by the ablation. So now let's see the fifth time of the microwave ablation. This time we changed our idea. We treated the tumor as a thyroid tumor with 30 watts and the small needle. This time we treated it very carefully for most of the bottom place. We can see after the ablation, this place, the bottom place, you almost treated, and only some of the top are still alive, active. So this time he feels much better because we use 30 watts with a low energy. He feels comfortable. There are no pain, there are no headache. So he feels very good. I think it's a good idea for us to treat him. Now we at the end of the last year we treated the sixth time, and this time it's smaller the bottom place. Okay. In 2 months ago, we treated the patient with the seventh time. He think it's good. Okay, that's the complications for our first about our first 657 case. The voice change is about 18 patient for four patients recovered about in 1 to 3 months, and 14 just go back to the normal voice in about 3 to 4 hours. And the hematoma about 53, skin burns only 1%, and local anesthesia intoxication about 3 patients, and the corruption about 1, and on about a little more than 10% the complications. I think it's acceptable. Most of the patient, the application is not so severe, I think. Okay, that's all my pretension. Thanks, everyone.
Thank you very much. That was excellent. That was excellent. So I'm going to kind of move us to a discussion, and I know I asked several of my questions throughout of the presentation, but I'd like to ask our team. Dr. Han has just gone through very interesting cases, and we're increasing our level of knowledge here in the U.S. But from our team or from any of the participants, what questions do we have for Dr. Han based on the cases? And that goes for the other physicians on the call as well. Feel free to chime in with any of the cases. I'll ask you one. When China started to really adapt and adopt these procedures, was it a collaborative effort between specialties and here in the US, it is still being defined what specialty is going to be the predominant performer of these procedures. Of course, it'll always be multidisciplinary, but did the group work together on tailoring and fine-tuning techniques, or how did that best? How was it cooperation best?
Okay.
I think simply, did the IRs get along with the surgeons as you began these procedures, or were there some challenges?
Erica, can you translate for me?
Yeah, sorry. Interventional radiology. Did interventional radiologists or ultrasound physicians get along with surgeons in the beginning days of these procedures?
Sorry.
Hey, Christian. Christian, let's maybe save all the questions to the end because we still have 2 more doctors to present, and this section is mainly for Dr. Yan, and since he already left, we can all ask questions at the end until the other 2 doctors presented. How's that?
We can do that.
Yep. Okay. So yeah, thank you, Dr. Han, for for your presentation. And now let's move on to Dr. Wei. And Dr. Wei, if you're here, please just briefly introduce yourself.
Yes, thank you. Can you hear me?
We can hear you very well. Thank you. And thank you again for your attendance as well, Doctor. We appreciate it. I know it's Friday evening in China.
Oh, thanks. So I will share my monitor. Okay, can see the slide, right? The slides. I share my slides. Is it okay?
We can see you very clear that the introductory slide showing your beautiful city.
Yeah. Okay. So today we are going to present our topic, the application of microwave ablation in complicated thyroid nodules, brought to you by Professor Yang Hui Wei and Dr. Jiawei Chen from the Thyroid Department of the 8th Affiliated Hospital of Sun Yat-sen University. So this presentation can divide it into 4 parts, including the brief intro and current progress of MWA and the operational procedures and summary. So let's come to the brief introduction. The classification of thyroid nodules according to the 2020 thyroid nodules classification in the China guidelines. The classification according to the composition of the solid components and the cystic component in nodules can divide it into the 5 categories. One is the solid, which composed entirely of solid tissue, and the second is solid dominant. Solid account for more than half, and the cystic dominant, solid account for less than half, and the 4th category is the cystic nodules, all or almost all cystic contents included, and the last category is the spongy. The nodules consist of a large number of small pockets, but without solid tissues. And this 5 picture shows the 5 category of the different types of nodules. So in patients of the thyroid intracapsular hemorrhage and cystic lesion, so this is the pre-operation, we can see a large mass in the anterior neck. And after the ablation, the large mass becomes smaller, and this is the fluid we extract from the cyst. In this kind of patient, according to the severity of the thyroid intracapsular hemorrhage, we can consider conservative treatment. In patients such as with less bleeding, no obvious pain, we can use ice pack and we can use hemostatic drugs, or we can select the surgical resection treatment in patient with more bleeding, massive bleeding, or patient with large nodules, or even malignant lesions. In the cause of intracapsular bleeding, there are 3. One is the pressure in the capillaries of thyroid nodules is increased by the external force, and second is operation wound, and the third is the tension of the thyroid sac increases and cause the rupture of the thyroid cyst. So in this case, thyroid cyst lesions associated with acute bleeding can be directly diagnosed with the following 3 features. Such as the neck mass increase rapidly in a short time, and we can see sediments within the cystic capsule, and we can also see a larger number of strong echo foci within the comet tails. And the last one is the deposits within a sac are mobile and without blood flow. So the second part comes to the current progress of the MWA. Based on the 2015 ATA guidelines for patients with thyroid nodules and differentiated thyroid cancer. So this is the strong recommendation, suggests that nodules with high suspicious ultrasound pattern. This kind of patient, they suggest the repeat ultrasound and ultrasound guided FNA within 1 year. And another strong recommendation is the patient with growing nodules that are benign after FNA confirmation should be regularly monitored. and most asymptomatic nodules demonstrating modest growth should be followed without intervention. So when it comes to the 2017 Korean Thyroid Radiology Society guidelines, this guideline recommends feasible combination treatment of alcohol with the radiofrequency ablation for the thyroid nodules in patients whose symptoms are not fully resolved after initial absolute ethanol ablation. So in China, we have our consents. This consents published in 2018. This consent suggests that in thyroid nodules are very common. However, most of them are without clinical symptom, and only observation is needed. Surgical treatment is the traditional method for large nodules with compression or asphytic problem. And in recent years, as the widely use of thermal ablation in different countries, such as China, South Korea, Italy, Australia, and other countries, they also start to announce their own expert consents. In the European Thyroid Association, there's a survey so that many experts are not familiar with the treatment of the cystic thyroid nodules by absolute ethanol. And the doctors are less familiar with the ablation operation and the application. So this is the criteria for ablation who meet all of the three articles and meet one of the and meet one of the Article 4. So I won't go detail into this the contents. And in the entire proposal for the standardization for ablation, this proposal suggests that for cystic or cystic dominant nodules, absolute ethanol is the most common ablation agent. The 2020 European Thyroid Association guideline, it considered that ethanol is the first-line treatment for pure cystic nodules and cystic dominant nodules, and thermal ablation is not recommended as first-line treatment, and it should be considered as an option for the recurrent cyst lesion after alcohol ablation and performed after an adequate drainage of the fluid. In the latest international multidisciplinary consent statement in 2022, this statement indicates that the chemical ablation is a very effective treatment for cystic or cystic dominant nodules. And also, again, the absolute ethanol is the most commonly used chemical and can be treated as an adjuvant to thermal ablation. I'm sorry. So when talk about the sclerotherapy for the thyroid cyst, the ultrasound-guided liver, kidney, ovarian, and thyroid cystic sclerotherapy has been widely used. And also in this case, absolute ethanol is also very common. However, there are some potential risks underlying. The ultrasound-guided cyst puncture, drainage, and the injection of sclerosis agent, it not only reduces the pain and risk of surgery, but can also achieve the therapeutic effect comparable to surgery. And the main indication of sclerotherapy is cystic lesion and in benign lesions. And nowadays, agents include the labromacrogol and absolute ethanol. It makes epithelial cells protein degenerate, and the cell lose the secretion function, and adhesion produce fibrosis. So as to achieve the purpose of closing the internal wall of the sac. So here we have a table comparing the pros and cons of absolute ethanol and labromacrogol. Absolute ethanol, as we all know, is very effective and with a good price. However, the con is the source is relatively limited in China, and the inability to obtain the drug approval. And second, the complications such as extravasation which makes the absolute ethanol maybe there are some potential risks for the patient. And another sclerosis agent, which called the leronmacrogol, it is also very effective. The serious adverse reaction are rare. This kind of agent has no irritation and it do not produce severe pain, and it doesn't like the alcohol. It does not have drug-like reaction and can be retained in the body for a long time. And the cost is expensive. So when comparing these two agents, the therapeutic effect of leronmacrogol injection in thyroid cyst is the same as that of the absolute ethanol, but the adverse reaction are significantly less. So this is a brief introduction of the leronmacrogol sclerotherapy. So in short, this is the most widely recognized sclerosis agent in clinical settings with low toxicity, less adverse reaction, and ideal efficacy. It forms the thrombosis and blocks the blood vessel immediately. And in the clinical indication, when the patient with emergency hemostasis or the esophageal gastric varicose vein bleeding and minimal invasive sclerotherapy of the varicose vein and can be used for minimal invasive sclerotherapy in the lower limb. The complication of this agent, it has side effect because of its intravascular injection. The most important side effect is that when it injects into the veins, it may lead to venous embolism, which may lead to the formation of drug emboli and life-threatening in severe pulmonary artery embolism. And when it comes to the leakage, it can also resulting in surrounding tissue necrosis, edema. So we must use this agent with caution. So the third part of our presentation is the operational procedure. We have several patient cases to share with you. In case 1 is the direct fluid drainage method. In this case, we have a 40-year-old male. The treat campaign is the patient find a mass in the anterior neck for more than 5 years. And the patient did not feel any comfortable, such as no fever, no palpitation, no sweating, no hoarseness, no dysphagia, dyspnea, and overeating and wasting. The ultrasound results show a single cystic solid nodules in the white loop, and the gray is Thyroid 2. And intracapsular bleeding was considered, and we find no significantly enlarged lymph node in the bilateral neck. And this is the PE. We find the trachea is still in the middle, and the nodule is about 4 by 3.5 centimeter with clean boundary, regular shape, and can move up and down with swollen. So here shows the ultrasound examination. It's a cystic dominant nodule in the white loop, and this is the diameter of the nodule. And we have the ratio of L to T is less than 1. Sorry. With regular margin and Thyroid 2. For the laboratory examination, the thyroid function is normal. And we use the contrast enhanced ultrasound to visualize the capture of the cystic nodule. And also we perform a computer tomography, CT, to identify the 3D location of the nodules. Then we perform the fine needle aspiration, and the pathological report confirm a benign result. So these 2 clips shows the hydrodissection process, which we also inject the saline to create a safe distance from between the nodules and the dangerous triangle. And also this is the fluid aspiration process. We just make a drainage and we extract the fluid inside the sac. And this 4 clips shows the procedure of the microwave ablation. We also use the moving shot technique and trans-ischemic approach. So this shows the demonstration of the microwave ablation. So we just make sure from the distal to the and after the MWA procedure, we use the contrast agents to evaluate the efficacy of the ablation. So we inject the contrast agent inside the vein, and then we use the CEUS to confirm that the entire area of the nodules is completely ablated. So comes to the case 2. This is the so-called double needle method. In a male patient age 45, and the treat companion he find a mass in neck for 3 months. And also this kind of patient, he feel no discomfort, and the PE, we find a 5 by 3.5 centimeter nodules in the wide loop. So this is the ultrasound. We see a 60 dominant nodules in the wide loop, and the diameter is 48 millimeter by 25 millimeters with a ratio of L to T less than 1, suggesting it's benign nature. And also we have a laboratory examination confirm a normal thyroid function in this patient. And also we perform a computer tomography to get a 3-dimensional information of the nodule. And we also perform the contrast enhanced ultrasound. And we perform the FNA to confirm this is a nodule goiter, which is a benign result for this patient. And again, we perform the hydrodissection for this patient. Okay. So this is the clips when we performing the ablation, and so this is the double needle aspiration. So the double needle, one is to inject the sclerosis agent, and the other one is the ablation needles. So once we have complete the drainage, and then we the ablation needle stay inside and start to ablate the nodule and also the internal wall of the nodule. So this animation shows the process of the microwave ablation and also the so this is the video of our the doctor and the assistant. They are doing the doing the operation. So again, we need to evaluate the efficacy of the ablation. We use the CEUS to confirm that a complete ablated area to cover the whole nodule. So case 3, we use MWA with the laromacrogo in a male patient 48 years old, whose chief complaint is the anterior neck mass was found for more than 10 years. So this patient has a normal thyroid function, and CT we see a large nodules in the right side of the thyroid loop. and the pathological reports show a benign result. So this is the protocol of MWA with laryngomacrogal treatment. Patient with the thyroid cyst and internal bleeding. First, we use this sclerosis agent to stop bleeding. And then after successful hemostasis, we use MWA to the thyroid mass. So this free kit shows the ultrasound guided punch and injection of this sclerosis agent. So this is the drainage of the fluid, and then the microwave ablation. And the last slide shows the evaluation by the CEUS to confirm a completed ablation. Case 4 comes to a CEUS guided method in a 80 years old female whose treat campaign is the neck mass was found for more than 5 years. So in PE, we see we can see a lump in the middle of the wide loop about the size 2 by 1.5 centimeters with clean boundary and regular shape. And also in the left lobe, we can touch a lump about 3 by 3 centimeter, also with a clean boundary and regular shape. So this is the ultrasound. The image may be a little bit blurred.
We can see it
And
clearly.
also, yeah, so I'm sorry for the poor quality of the picture.
No, we can see it. We can see it well.
Okay, yes, okay. So for this patient, the thyroid function is normal, just with a elevated anti-TG level. And this is the CEUS and the CT results of the nodule. And also FNA confirmed benign results. So in this patient, when we perform the aspiration of the fluid inside the nodule, it comes to a bleeding in this site. So we further use the color Doppler to identify the bleeding sites. To better visualize the bleeding site, we further use the contrast agent, and now we can see clearly the bleeding site here. And then after we confirm the bleeding site, we use the microwave ablation to stop bleeding under the CEUS guided.
So that for the group on our side, that's a major benefit of microwave ablation is the ability to coagulate the blood post-procedurally and
Yes.
stop bleeding.
Yeah, stop bleeding. So it's the advantage of the MWA.
Absolutely.
Yeah.
And that's another area, as we educate physicians in the U.S. market and they learn, Doppler's an area that you don't see that often. And I don't think I have seen very many cases of that technique right there either.
Oh, okay.
But they need to be. It's just areas that we can teach and educate physicians in the U.S.
All right. So let's go to the MWA process. So this is also the routine method, the moving shot technique. We just to make sure the ablated areas to cover every part of the nodules. And validation of the complete ablations. So in case 5, we will share the experience in the multiple ablation. This patient is a female, age 53 years old. Her chief complaint is the neck mass found for 1 year. This patient have a relatively large mass. The size is about 4 by 3.5 centimeters. So according to the latest ATA guidelines, the nodule with volume larger than let's say 20 to 30 millimeter. So it is suggested that you should perform the multiple ablation for this kind of patient. So this patient, he has an elevated anti-TPO level and also an elevated TG level, but with a normal thyroid function. So this is the first time we perform the CE, US, and FNA in this patient. We perform the FNA in both nodules, and the pathological report confirmed a benign result. And this is the first time microwave ablation. These 3 clips, originally it was animation, but I don't know why it becomes picture. So this is the second ultrasound. The first time we perform part of the nodules, and the second time we will perform the ablation in the rest of the nodules. So the animation doesn't work here. The animation, I'm sorry for the technical problem.
No problem. Hey, when you say the guidelines mention, for this type 2 ablations, and I apologize if I missed it, does that mean 2 separate sessions that you will bring the patient in on? Or is that, or maybe you can elaborate for me on that?
So according to the ATA guidelines, it just clarified that the nodule with a volume larger than 20. In the guideline, it says 20 to 30 millimeter. So this kind of nodule suggests multiple ablation. So in our case, this patient is absolutely larger than 30 millimeter. So we consider multiple MWA for this patient.
Understood.
Yeah. Okay, so this is the second chart. Oh, okay. And this is the second time to do the CEUS and FNA because we need to confirm before we perform the ablation, we need to confirm a benign pathological report. So this is the CT. We see the ablated area from the first time ablation, and also the laboratory examination. And this is the second time ablation procedures. And the animation doesn't work again. So basically it's almost the same with the first time ablation, but we just make sure to ablate all the remnant tissue of the nodules. Okay. So we use the CEUS guided ablation to make sure we have diminished all the remnant nodules. Okay, so we have come to our conclusion part. From our experience, we can say that the thermal ablation is safe and feasible in the thyroid hemorrhage nodules. And the leromacrogol, this kind of sclerosis agent can be used in the TA. And in case of another intraoperative intracapsular bleeding, continued ablation after CEUS-guided hemostasis is a more safe and effective option. And multiple ablation is feasible and safe for patients with large thyroid nodules. So that's the presentation I want to share with you today. Thank you so much.
Very, very well done. Very nice. And thank you very much.
Thank you.
Okay, yeah, thank you, Dr. Wei, first of all. And now we can welcome Dr. Han, and then after that we can have a discussion section together.
Thank you, Eric. And again, well, welcome, Dr. Han. Again, appreciate your time on a Friday evening. We're very grateful for you to join us.
Okay, thank you. I'm Bing Han, or you can call me Bing. I'm from the Department of Endocrinology, Nice People's Hospital affiliated to Shanghai Jiao Tong University School of Medicine. Today, I will give a lecture about the thermal ablation of benign thyroid nodules. So I'm the last speaker in this day. So let's begin. The first part is a brief introduction. In the brief introduction, so what's a thyroid nodule? Thyroid nodules are lesions caused by abnormal proliferation of thyroid cells. There are many factors for thyroid nodules. First is iodine deficiency. You know, in China, many people take the non-ideal salt, so they have the risk of iodine deficiency, and iodine deficiency is a risk for thyroid nodule. The second is radiation. You know, in former Soviet Union and Japan, after the nuclear power plant closure,
yes,
the incidence of thyroid cancer is skyrocketing. The other factors include genetics, data, etc. The clinical symptoms of thyroid nodule mainly include these two aspects. The first is pressure symptoms, such as hoarseness, foreign body sensation in the throat, difficulty in breathing and swallowing. The second is hormone-related symptoms, such as palpitation, excessive sweating, trembling hands for hyperthyroidism, and feral cold fatigue and drowsiness for hypothyroidism. There are also the classification of thyroid nodules. Most of the thyroid nodules are benign thyroid nodules, and only 5 to 15% of thyroid nodules are malignant. In malignant thyroid nodules, most of them were papillary thyroid carcinomas, which is called PTC, and others were follicular tumors, medullary carcinomas. So how to differentiate a nodule? Which one is good and which one is bad? So we use the thyroid system to differentiate it. You know, in US, there is ACR thyroid in US, or EU thyroid, also in Korea, there is K thyroid. So in China, we have C thyroid in 2020. This is the guideline for ultrasound malignancy risk stratification of thyroid nodules. So in C thyroid, there is 5 positive features, such as vertical orientation, solid composition, marked hypoechoic, microcalcification, and irregular margin or extrathyroid extension. Each one has 1 point. And there is also negative features, comic tail artifacts, -1 point. So when the patient have 2 positive features, there are 2 points, and 2 points is C thyroid for B level. So the malignancy rate was 10 to 50%. Before thermal ablation, fine needle aspiration biopsy is needed for this patient to differentiate benign or malignant nodules. Using the image-guided ultrasound, image-guided needle, we could drain some cells from the nodule, and using the microscope, we could differentiate in cytology. And the diagnosis and the treatment process of a nodule are as follows. First, when we find a nodule, we should ask the history, physical examination, and thyroid function test, also ultrasound examination. When the TSH was lower than normal range, so we suspect this nodule has a function. Next, we will have the ECT test of the thyroid. When the TSH was in the normal range or beyond the normal range, so clinical evaluation of the FNA was performed. So when the nodule was benign, we could next we could follow up over the observation or thermal ablation. When the nodule was undetermined thyroid nodules, so we have the second time FNA or core needle biopsy with genetic test or follow-up. When the nodule was confirmed or suspected thyroid cancers, we could use the surgery. So when we meet a malignant nodule, surgery is the first choice. In some cases, we also could use the thermal ablation. When the nodule are benign, so we could follow up or surgical treatment. Sometimes we could use the internal medicine treatment, which is called TSH suppression treatment, or in some functional nodules, ideal 131 treatment was used. And the last and foremost, ablation treatment, we should not forget. The second part is the thermal ablation for thyroid nodules. This is the picture of the comparison of the surgery versus thermal ablation. This is the thermal ablation operation scenery. When we compared the surgery with the thermal ablation, after traditional surgery, there was a long scar in the neck. However, after some ablation, there was a small needle eye. So this thermal ablation was very friendly to the patient who has cosmetic concerns. This is a traditional surgery, and we lost one lobby of thyroid. However, after thermal ablation, we could maximally preserve the normal thyroid function. When we perform the thermal ablation process, we follow these two guidelines. The first is the China guideline, and the second is the European guideline for benign thyroid nodules. And also in Chinese guidelines,
All right, Dr. Han, we might not be able to hear you.
Yes, if you can hear us, Dr. Han, we have hit a spot where we are on the guidelines slide, the 2020 European Thyroid Association guidelines. So, not sure if there's anything you can do on your end to help advance, or if you can. First off, can you hear me at all, Dr. Han?
yeah,
Okay. So Eric, the person that is advancing the slides, can they hear us?
So the slides that we see right now, they're presented by Dr. Han, and if you don't mind, I can start sharing some other slides for you guys to see until Dr. Han is back.
Yeah.
people.
Yeah, we can hear you for a bit.
Yeah, for some reason we can hear you, Dr. Han, but it does not appear that the slides are advancing.
Okay, so maybe we can have a little discussion until Dr. Han is back, and we can get back to his lecture.
Yeah, and I think his audio is coming in and out, so I'm not sure questions would
Okay.
be received and the responses would be received. Although that is a very important slide that we landed on, because that 2018 and 2020 guidelines really were what opened up the market and the acceptance of microwave and thermal ablation of the thyroid. So we did land on very impactful slides to
Hello.
where we are today.
Yep, we can hear you for a bit. Maybe you can try to just turn on the audio and not the video to see if it works better.
You may need to message that to him, Eric, in case he is not able to hear us.
Okay.
And another option could be to have him email his deck. And while we're waiting for Dr. Hahn, and for those that on the call that may not be as familiar with where the U.S. market is, you could probably tell from some of my questions. Well, there we go. We're coming back. So, or are we going to me? Okay. For those of you that aren't familiar as innately with the U.S. market, the U.S. is distantly behind other regions, with the other regions being led by China. And China's, distantly ahead of Italy and the European markets. So really just in the last, 18 to 24 months have thyroid ablation procedures been accepted, and still by a smaller group. And you heard me touch on the guidelines that came out in China in 18 and then 20. We just, in the US market, received guidelines in September of 2023, published by the American Thyroid Association, acknowledging the benefits and the overwhelming data, international data, for the efficacy and safety of this procedure. So that really is a major step forward to begin, a greater level of adoption. Now, with that will come, data collection, which will then advance the procedures and the techniques. But some of the questions I'm asking are fairly basic in nature, especially for the very experienced physicians we have on the call from China. But it's because not only what our sales reps are asking, it's what physicians are asking. The physicians in the U.S. are still learning techniques, still learning different best practices. And that's the value of having, and we greatly appreciate the colleagues from China joining and sharing the experiences that have been learned through years of developing the best practices of the procedure. So another element in the US is the procedure, although surgery, for all the reasons we know, is not the better of the two procedures for most patients, and it's more costly. This procedure, both RF and microwave, are still not approved via most insurances. There's a few insurances.
Christian, if you don't mind, we can maybe just have a little discussion, because since Dr. Nwagu is here.
Yep.
And if Dr. Nwagu, this is Christian. If you have any questions to ask to the doctors, feel free, because Dr. Han, the other Dr. Han is here, Dr. Wei is here as well. So while we're waiting for Dr. Han gets back, we can maybe have some discussion if you have any questions. Otherwise, Christian, do you have any questions to the to Dr. Wei, either Dr. Wei or Dr. Han.
Yeah, well, I'll ask Dr. Nuego. I mean, when being a U.S.-based physician, what was it that, captured your interest? And, as as you've started to learn your skills and hone your skills, what has been most beneficial to you? What resources do you have, and what resources can be provided to physicians such as yourself that are looking to continue the educational pathway?
So first of all, are you asked who are you asking that question to?
Dr. Nuego's in the U.S., correct? And
Yes, because uh I believe she although she's in the Zoom meeting right now, she might not be very much connected. So maybe we can pass the discussion to between you and the two Chinese doctors, if you don't mind.
I don't mind. I can work it. I can work with that, Annette. Um,
Yep.
but so it's going to be similar educational pathways and markets. The people are people and procedures are procedures. So as we Baird Medical looks to educate the physicians, when you were starting, first year of your career and doing these procedures, what were some of the most beneficial things that we could provide as a company to be a partner to this specialty? And I'll add on one other.
Okay, can you please maybe just paraphrase your question and keep it as short as possible because sometimes I believe the language barrier is there. The doctors might not capture it fully.
Yep.
But before you ask, let me please just kindly ask if Dr. Han Feng and Dr. Wei Yanhui, can you please, are you here? And if you are able to answer questions, that would be awesome. All right, Dr. Han Feng.
Yeah, I'm here. Can you hear me?
Okay.
Okay.
Yes.
Uh,
So yeah, we were just saying that since the other Dr. Han is
okay.
tentatively out, maybe we can just pass it to a small discussion section between you and Christian. And we
Okay.
also have another US doctor, Dr. Noago here,
No,
while I
yeah.
believe she might not be available at the moment. So we can just have a discussion between you and Christian.
Okay. Thank you, Chris. To my opinion or to my experience, I will share some my experience. Before the ablation, I suggested we should do some biopsy. It's much helpful for us to know how to use the needle, how to control the needle. Make sure, it's very similar between the biopsy and the ablation. It's use one. I think you use the same one technique. I think so. Before you do the ablation, I think you should do a little more exercise about the biopsy first. Not only the FNA, core needle biopsy is okay too. First, the second, before you do ablation, you can try to have some exercise on the phantom. I think it's very useful too for improve the skills. I think. Uh, and I think
Yeah.
that's enough.
Yeah,
Thank you.
Christian, that's the answer from Dr. Han.
Mm.
And
Sorry, guys,
do you,
I was muted.
yeah, while he was as he was presenting his slides just now, looks like you have some question. If you have any still, feel free to ask it.
Yeah, no, I think you touched on the minimum. People have to be skilled with ultrasound. There's a unique dynamic different in the U.S. where physicians are not required to be licensed to do this procedure, where it's my understanding they are in China. So there's an obligation of the company to really educate. phantoms, ultrasound, any other suggestions of things that we can do to encourage these physicians to be comfortable in doing the procedures beyond those two things. And Eric, feel free to translate. It'd probably be helpful.
Yeah, so if you don't mind, when you ask a question, can you kind of like, ask it in just one or two sentences? You don't have to like put multiple questions in one sentence. Otherwise, it might seem a bit complicated to Dr. Han. Just saying.
Can you translate for me?
Yeah, can you say that
Yeah.
one more time and
Yeah.
just very, very short? Yeah.
Yeah, no, I said, beyond, ultrasound skills that we know they have to have and working on phantoms, what was the next step that we can provide to our physicians as an educational element?
Yeah, Dr. Han, did you capture that?
Yeah, catch it. After you access on the phantom, you can work as an assistant with the doctor. Try to feel and try to learn how to work with the how to work the ablation works. Then under the direction of the who has a license, and you can try to do some easy nodules, small one, safe place. I think it should come from this kind of nodules. Then from step to step, then to try to challenge difficult nodules, big nodules. I think it's a good step. Maybe to our opinion, maybe 30 cases is needed to make sure you can handle most of the situation. Because you don't do much more, you will not able to face difficult situations, different situations. So you need to try to do a lot, then you can find, oh yes, here this one is a bleeding one, how to treat the bleeding. This one is a septic one. It's easy to treat, how to treat. Oh, I think it's good.
Understood. Trying to think how to ask this in a concise manner. And I'm asking real world questions that have come up, but I'll start with a quick one. Do you see much radio frequency ablation in China targeting the thyroid?
You are talking about the radio frequency?
Yeah, is that
Yeah. We also did some radio frequency some years before, before we use the microwave. I think it's a good choice, but sometimes it's the energy. All the difference between the radio frequency and the microwave, I think, is the energy. Radio frequency isn't fast enough, I think, sometimes, especially when we facing the bleeding situation. We need a very high power we need. So sometimes maybe not so good. I think not so good, to my opinion. Because we have faced several cases of bleeding. This kind of bleeding is not inside the thyroid. It's outside the thyroid. You will see that the neck bounced up very quickly. So we need to find where is the bleeding place and to calculate the bleeding, or very stop the bleeding very fast. So we need to with a very high power, maybe 50 watts. So in this situation, the microwave have some advantage. In other case, it is the big one. We usually do some very big, more than 5 cm the nodules. If you use radio frequency, it will cost a lot of time, I think.
Understood. That's very helpful. Thank you. One of the a technique that a sales technique that
Mhm.
the radio frequency companies are utilizing against microwave is penetration of the needle, since they have a smaller needle gauge in most cases. How would you suggest we address their concerns, the physician's concerns, of it being a larger needle and the patient hoping to not have a scar?
Okay, I don't think the scar is a problem because uh maybe I think there are two questions. First, some doctors think the radio frequency is much sharper than the microwave. Yeah, not too sharp. I don't think it's not an advantage. I think it's a one advantage for us, especially in thyroid. There are too many vessels inside or surround the nodule. If it's too sharp, it's really dangerous to break the vessels. Not too sharp is safe. I think it's a safe model for us. Can maybe save. I think. The second problem is about the scar. Now before we puncture the microwave needle into the neck, into the nodule, into the thyroid, we should uh, as before we cut the skin. Now we need not need the knife cut the skin now. We use a big needle, a very big one needle, just punch a small hole. And in this technique, we found there's almost no scar were found in the skin. I think don't have to care much more about scar.
That's fantastic, and we're starting to see physicians adopt the initial puncture needle. What gauge size do you typically use for that initial stick?
Oh, I don't remember exactly the gauge. The biggest one, uh, uh, in China, I think I don't know. I don't remember. Sorry, it's a
I,
little bigger than the.
I was going to say,
It's maybe 14, maybe 14 or 12 gauge. I think.
that's how I was going to ask it. Is it bigger than the microwave ablation needle?
Yeah. A little bigger than a microwave.
And do you penetrate not only through the skin, the percutaneous piece, but do you penetrate that needle all the way through the capsule of the nodule?
Actually, I just punctured for the skin. I think it's enough. Sometimes I will punch to the needle in only one situation. It's a liquid one, and the liquid is very hard to stick. It's very stick liquid. I use this needle to drain them out.
Great. And as you can see, I'm taking many notes because these are the things that we are coming up against. I think a lot of it is planted by our competitors. So, and I'll put it out to the group as well. Our group is seeing physicians on a daily basis. What questions does the sales team have that you would like to get an expert such as Dr. Han's opinion on? Then I'll kind of keep going. So because of the young nature of the procedure in the US, there is not much, really any long-term clinical data on microwave ablation. We are going to begin studies that are head-to-head of microwave ablation versus RF. But that's a year follow-up, time to pull the data together. Are there any other studies, data collections that you would think that would be beneficial for us to initiate while the more thorough reduction rate studies are taking place?
Okay, there are many study about the reductions, not only the benign, but also the malignant. Actually, some professors, some experts are talking about the VRR, the reduction rate, recently. I think it's very interesting. They think to the benign nodules, reduction rate is very useful, as we know. This is what we want to do, what we evaluate the effect. But for the time, you just talk about the time. We most of the study is about 2 years. I think it's enough. Yeah. I want to see another question is about the reduction, is about the PTMC. In recent days, some experts are talking about the reduction of the PTMC. They think it's hard to use this use the reduction rate to evaluate the PTMC after ablation because it's very small before the ablation. But when you finish the ablation, the area is very big. It's much bigger than the lesion itself. So we think it's not a good thing. But I think we can use the first mouse size to evaluate the effect. This is what we just do. So every time we compare the size after the first month with the first month after ablation, I think it's a good idea.
Great. I know we have Dr. Moga here, but I just had one more question. It came out of a procedure we saw just a couple of weeks ago. Do you hydrodissect in every procedure, and the specific one where this physician, very skilled at RFA, did not hydrodissect was an extremely large, it was 6 cm, benign nodule, and he did not hydrodissect? Would you have hydrodissected in a case like that?
What case?
It was a 6 centimeter benign thyroid nodule.
Even the bigger than 6 cm?
Yes, he did.
Yeah, we have the biggest one, the solid one we have made is about 10 cm.
Oof.
It's really big, from maybe the whole neck from the top to the bottom. But not so good, I think, because it's too big. It's hard to absorb. I think the volume reduction is not so good. So now the big one, bigger than 7. I think 7 is good, as you said. Bigger than 7 cm, we usually advise them to have an operation.
Great.
Okay.
Thank you very
Yeah,
much.
thank you guys. So, Dr. Nwago is here. She was very happy to be here and was very much waited to ask questions to both you guys. So, let me just briefly introduce her before she pops in and turn on her audio and video. So she's an MD in Los Gatos, California, and they currently practice and are affiliated with El Camino House Mountain View Hospital. And she has experience treating conditions like endocrine tumors, among other conditions, at varying frequencies. And the present, she received an average rating of 5 out of 5 from patients and has been reviewed 6 times. And their office is not accepting new patients, but she's board certified in general surgery and accepts multiple insurance plans. So yeah, welcome, Dr. Nawaki. And if you are here, feel free to turn your mic and ask questions.
Hi, Dr. Wago.
Hi, good morning or good evening. I think it's evening in China, and good morning to
Yeah.
those of us here. I appreciate the presentations. Thank you for getting them all together for us. I missed the beginning, I have to say, but actually someone was answering one of the pressing questions I had. So I'll just go back to it since it's still a recent question. There was the discussion about RFA needles versus NWA needles. And my understanding is that for what I gleaned from you all is that for the NWA procedure, you would use perhaps an 18-gauge needle to puncture the skin to then make it feasible for the needle to go through the thyroid. And you still don't have any trouble with the needle getting through the thyroid capsule, correct?
Yeah, I don't think it's the trouble.
Okay, and you don't have to make a separate, if you use an 18-gauge needle, you don't have to make a separate incision. Is that right?
What decision?
If you use an 18-gauge needle to puncture the skin, you don't need to make a separate incision with a scalpel to get your probe in, correct?
Yeah, we just use another sharp needle to break the skin. I think that's okay. The capsule of the thyroid usually is tough, but when you put your microwave needle on the surface, you may think it's tough. Most of the case you can through, just use the needle. Some cases, even you think it's tough, it's hard, you can ablation it. Just step on the pad, and for 1 or 2 seconds, you can through the capsule. I think it's okay. First, second, you can stop bleeding sometimes, I think.
All right. Well, that's thank you for answering that. That's very helpful. I also think that well, Dr. Yoon, I came on shortly before Dr. Yoon had to leave, so I actually heard his question, and Professor Wei might have answered that question as well. So I'll ask it again just for the sake of clarity. When you have cystic nodules or mixed nodules, cystic and solid, Dr. Yoon was saying that in his experience, he's found people who are not aspirating cyst before ablating the solid component. But you all, I think what I'm understanding from those of you with far more experience is that you are still completely draining the nodules and then ablating either solid portions or the sac or the line of the cyst. Is that correct?
Yeah.
Is there a reason why you have stuck to that? Because he's saying that he's noticed more bleeding in cases where they completely drained the cyst. Why? How come his experience is so different?
Actually, we drain out the liquid inside the cystic one. The most we want is to shrink the nodule. It becomes smaller, and we can save time. We can finish the ablation very soon.
Okay.
Yes. If it's bleeding again, we treat it as what Dr. Yu said. Just treat it as a solid one and ablate from the solid part. I think it's okay. And the VRR, the reduction rate is same to our opinion.
All right. So I've got that. I was also going to make a comment. I'm also answering a question that I believe someone asked when I wasn't able to speak earlier. Someone asked why I was interested in this. I'll also add onto that what I see as a way forward for some of us physicians in the US. I'll say I've noticed that the doctors who have adopted microwave ablation, the few I've noticed who have adopted it here in the US, they've had prior experience with RFA. And so they had an easier process transitioning into microwave ablation, because some of the key principles, the key procedural principles stay the same. But for surgeons like me, I'm an endocrine surgeon, so I do countless FNAs and a lot of endocrine surgeries, thyroid and parathyroid. I've gotten interested in this ablative technique because I see it as a really viable option to offer some patients who are, one, not operative candidates, and two, patients who are on the borderline and are very anxious about their nodules in spite of medical advice telling them that it's most likely benign and everything's fine. It's great to be able to offer them an option. I also see the utility of the microwave ablation in particularly metastatic thyroid cancer in the lymph nodes. I see that that's something that you guys are actually already doing in China as well. So I see value to this technology. I do think that a big hurdle would be the training process. To get greater uptake for surgeons and physicians like me, who may not have already, I was actually already considering RFA when I met one of your agents. To get greater uptake from people like me, there would need to be some training, some formalized training. That way, when we discuss this with our patients, we can also we can essentially assure them that we have gone through the process, we have read all the papers, and we have trained adequately to do this. I just wanted to offer that feedback here, but everything I listened to was, pretty excellent. I'm happy to have heard it, to have gained a bit more understanding than I did previously. So thank you all.
Thank you. I think you will do very good.
Thank you. Thank you for your confidence.
Thank you.
I look forward to working with you all in the future.
Yeah, maybe. I have been in California. I have been in San Diego for 1 year.
Oh, you will be in California?
Yeah, I have been in San Diego for 1 year.
Oh, you were there for 1 year. Oh,
Yeah.
well, let us know when you're coming back. Maybe Connie will let me know.
Yeah, of course. Maybe you can come to China. You must let me know too.
Well, that would be nice. I just have a lot, so it'll have to take careful planning.
Yeah.
Lovely to meet you all. Thank you for your time.
Thank you.
If any,
Glad meeting.
yeah, same here.
Sorry, go ahead.
All right.
Hey, Dr. Dwago, I was going to mention one thing that because I asked the very similar questions. My name's Christian. I'm with Baird. One thing that I asked about the access needle, instead of an 18 gauge, they said they typically are using. He didn't know the exact gauge size, but a needle that is a size larger than the 17 gauge microwave ablation probe, and have found better success with a little larger diameter of a needle.
Oh, got it. So they're using a larger diameter needle or probe. Got it.
Correct. I had the exact same question. So
yeah. Well, I appreciate the clarification. I've actually been getting some information from Connie, so it's been helpful to review the available data and to maybe spend some time studying the European guidelines and the guidelines out of China as well. So I look forward to having more discussions with you guys.
So I was on mute, and absolutely, you mentioned training; it's so critical. As you're thinking of different things, Baird. I know Connie's probably educated on it. Baird's reputation in China and market leading position was established on education. So, we would like to support you in every way we can on those educational endeavors and experiences to get you comfortable. So, please let us know what we can do to help you, and we'll let you know as we are conducting classes. But the goal is to have multiple training centers here in the U.S. Would love to have you participate in those.
Absolutely, absolutely. Connie's been she's been excellent at keeping me updated on what's happening. So hopefully when there's a class available close to me, I would love to participate.
Absolutely. Right. And perfect.
Right. Well, lovely to meet everybody. I'll turn my computer off so I can continue working, but I am listening. Thank you very much.
Eric, I saw a message come across from you.
Yep. Yeah. So, well, first of all, thank you, Dr. Nwago, for showing up and asking some very good questions and making that connections at the end with Dr. Han. And so, unfortunately, at the moment, it seems like the other Dr. Han might not be able to join us on time. So we can either continue our discussion for a little bit, or uh, if not, then maybe we can try the end.
I don't know what your level of confidence in him being able to rejoin is. I know that's a very subjective question.
Yeah, so my latest update regarding his status of rejoining the meeting is that he still have connection issue with Zoom on his laptop. So I'm afraid that it is not something we can resolve momentarily. Our colleague is working to help him out, but I'm afraid still that he won't join us in any short moments.
Understood. I would make the suggestion then that in light of everybody's valuable time and their generous contributions of that time, that we don't sit and wait. And for those of you that may not know, that this is not going to be a one-time session. This is an ongoing endeavor to educate. Continually educate the U.S. market and share practices across regions. So, if he can join another time, that would be an option as well. But there'll be various general topics and specific topics with different physicians, with different techniques, and these will be recorded. So we can go back if somebody's not able to make them. So it's not a one-time have to do it now or it doesn't occur. We'll be able to do it, and that's Baird's commitment to this specialty and to this procedure. And that's one thing that makes us unique. We're not trying to be everything to all organs. We're really trying to focus on thyroid and be a partner to the physicians that treat these diseases. I think that may leave us with the last discussion points. If there's any questions or stones left unturned, if that translates, I'll kind of open the floor to anybody that has that question. Please ask now. If you're thinking you're going to call me afterwards and ask the question, feel free to ask the experts that know it. Give a couple seconds on that, and if not, then I think we can conclude the meeting. Well, I think the silence speaks volumes. I want to reiterate to all of the physicians. I know the amount of effort that goes in well ahead of these to prepare your presentations. Not to mention the experience to get you to the point of being able to deliver so eloquently the presentations. And I want to personally thank you on behalf of Baird Medical for taking your valuable time away from your families and other events on a Friday evening in China to join us and help advance this very exciting, innovative, and frankly patient benefiting procedure forward. So you have our sincerest gratitudes. Thank you very much. And we look forward to seeing you on these calls in the future. And if there's anything we can do to support you, you know where to reach us and our Chinese colleagues. I would also like to thank everybody from our Chinese team that has helped coordinate pulling these together, and Eric as well.